Hi, good evening, and welcome to tonight's CPD webinar. My name is Andrew Ormrod, a bit of a stranger to these webinars. It's about 8 months, I think, since I've done a live webinar, so I've got lots of buttons to press and a great potential to make a mess. And there's no pun intended in the rhyme there, but I'm just going to check with Stephen that you can see my welcome screen. Can you see that all right, Stephen?
Yeah, I can see that fine.
Oh, that is fabulous. Well, at least that's a good start to tonight. So we're just going to give people a few minutes to come online, and then I will walk you through some of the bits and bats of what's going on this evening. So if you are familiar with the webinars, you'll know that we've got a chat option and a questions and answers option. So I please invite you to pop into the chat, maybe where you're dialing in from tonight, maybe what excites you around mental state examination. And let me see if I can see that. I can see David, evening, paramedic working in the Peak District. If it's anything like Lancashire, David, it'll be wet and wild because if I had any air, it would have blown off tonight on the way here. So good evening from the Peak District. It is wet here as well, I can imagine. Alexander, paramedic, LAS control room. Good evening, Alexander. Equally important. Andy from Sussex. Oh gosh, it's going too quick now. Daryl, good evening. Mark, Donna, student paramedic from, I think she's at Manchester, EMT in Wales. Gosh, Wales. Oh, we've got an international market tonight now. We're all over. Liverpool, student paramedic Grace. Oh, there's too many there now. You can keep track with all those very fast-moving chat. So tonight we have got Stephen Marks. He's back again for the second time. That good for the first time. We've invited him back talking mental state examination. So, but before we go any further, I'm just going to tell you, we've just been chatting with Stephen. We're going to cover some bits and bats tonight. I think Stephen's going to come back and cover another session on psychosis. So we chatted earlier today. I'm getting the affirmation nod from Stephen, which is good. And then we're hoping to put together an amazing series for anybody working in an advanced primary care environment to allow you to assess and support people presenting with acute and long-term mental health problems, including some amazing safety netting tips. So I'm going to tell you how to subscribe to us and download the app to make sure you don't miss out on those good opportunities. Sarah, hi from NW, military medic in the islands. Good evening. First responder John from Coventry. And we've got Annie, OT. Andrea, who's OT. Oh, I'm confused now. Andrea says Annie, but you've signed in as Andrea. Oh, gosh, that is confusing. Anyway, let me tell you some rules and facts. You've probably noticed we've got quite a posh little slide set tonight. So we can't hear you and we can't see you. So if you're sat there in your satin robe or you sat there in your gym attire, or maybe you're still sat there in your uniform, don't worry because we can't see you and equally we can't hear you. As I've said, and you are already you've got with it already, people are interacting with the chat, so please interact with each other on the chat, but please be courteous. So any misbehaviour on the chat, it'll be my responsibility to give you a shot warning. We've had some occasional shots needed to be fired before in the past, so please be pleasant and polite on our chat. But if you do have any questions for Stephen, please do pop them into the question and answer box, and we will answer the questions at the back of tonight's webinar, and we'll get through as many as we can and try and keep it within the time frame. Members of CPD-Me. So if you're a premium member of CPD-Me, of course, you will get your certificate, and that will come within 24 hours of the broadcast when my amazing team in the other room wake up tomorrow morning and have their scones. You will get your certificates. And if you've got your app downloaded with notifications on, you will get a notification when them certificates arrive so that you can reflect upon tonight's learning. And of course, the certificate and the evidence will automatically populate into your portfolio, and that's what makes CPD-Me magic. Lindsay, OT from Care. Welcome on board, Lindsay. And we've got Sarah, who's a mental health nurse from on the sofa. That's the best place to be for this type of learning, Sarah. Best place to be. And of course, access to this recording when it's all trimmed tomorrow without me chatting within it. Oh, we've got Bulgaria, see? Look at that. Firearms instructor, John. Good evening, John. Welcome on board. Now we really have got a true international market. So, here's our new social media slide. I didn't even know. I've got an EMT from Spain. Good evening, Glenn. I didn't even know we've got a TikTok account, and you can be absolutely sure you will not find me on TikTok. Maybe we can get someone to do a TikTok video tomorrow. But if you are on social media, please do follow us on Instagram, Twitter, and TikTok. And if you picture yourself as a selfie tonight, wherever you're doing, whatever you're learning, whether you're at work or you're on the settee, picture yourself, get a snap and share it on our social media. And we've got 2 12-month free memberships to give away. So please don't forget to tag us with CPD Made Simple. I'm not sure how TikTok works. My daughter does a lot of TikToking, but I'm not sure how it works. Yes, you do get a certificate. Sorry, you have to be a CPD member to get a certificate, Zara, and I'll tell you all about that at the end. Feedback is important to us here at CPD, so please do leave us some feedback. Up on the screen now, we've got Trustpilot, Google App Store, and Google Review, and we have, of course, always got 2 £25 vouchers. I'll give one away tonight, so please take a picture and scan them QR codes, and I will give one away tomorrow. So they are digital Amazon vouchers that just get emailed to you, because feedback is really, really important to help us move the business forward. And more importantly, throughout this difficult time, support and retain members. So genuine feedback is uber important to us. So please do scan them QR codes and leave us some feedback. 7 reasons to be a member of CPD. It does make recording CPD simple. We all know that for those people who are CPD members. Is anybody online who is a CPD member who uses us, either the app or the website, to capture their CPD? Just give us a "oh yeah" in the chat so I can see we've got some people on board. And I'm sure there'll be testimonial to how recording CPD for your portfolio, whether you're HCPC, NMC, GMC, is made super simple. And you can see on the screen there's lots of other great benefits to being with us. So, yep. There's lots of people, really easy to use. I saw that very quickly move then. So we've got 3 levels of membership. We've got a free account, which limits the amount of CPD you can put on there, and you also don't get certificates. We've got the £1.99 trial, and we've got the full membership, and it is just £17.99 per year, and that is price frozen. So it will not go up. In fact, we've just had a price increase. That was the first price increase we've had in 10 years. So we really are trying to keep cost affordable, because we know that budgets are tight out there. Maldwin, great testimonial there, being called for audit. That's a good reason to maintain a continuous record of your CPD. So thank you for all those people who put thumbs up out there tonight. I really appreciate that. But scan that QR code for either a free account to have a little test, the £1.99 trial, or to be a full member. Lots and lots of really good testimonials there. Fabulous guys and girls. Brilliant to have you on board. Right, that's enough of me chatting now. I'm going to hand you over to Stephen. Are you there, Stephen?
I am here. Yeah, can you hear me okay?
Fabulous. Hear you and see you perfectly. So I'm going to hand the screen over to you now.
Fantastic. Let's see if this works. We did practice it. How's that?
Perfect.
Wonderful. Shall I crack on then?
It's all up to you.
Thanks very much, Andrew. So thank you all for joining us. I still find it quite bizarre that I'm speaking to hundreds, if not thousands of you, but can't actually see you. But we'll give this a whirl. And I have built in some time for questions at the end. And, if we're getting good content coming in, more than happy to stay on and have a little chat about that, get some good questions. So tonight we are going to be covering the mental state examination. Before we do that, I just wanted to start with a little bit about me. So I've been qualified as a registered mental health nurse since 2013. I've held loads of positions, sort of started out in PQ, psychiatric intensive care unit, but I've worked in crisis teams and community mental health teams. But by and large, the vast majority of my experience has been in emergency and urgent care. So I've been an A&E liaison practitioner. I've also worked quite closely with NHS England on the Sequin project, where I worked with frequent attenders to A&E. And I'm also a qualified advanced nurse practitioner. And in 2021, so I've coming up to a year now, I've been employed as a senior lecturer in mental health nursing. So I think, over the course of my career, I've completed thousands of risk assessments, mental state exams, and my current research and teaching passion really lies within this field. So I'm delighted to be talking to you tonight about this. So what we're going to be looking at tonight, we're going to be looking a bit of an overview of kind of mental illness, SMI, what's the difference. We'll look at depression, we'll touch on bipolar, and we'll think about how this all comes together when we're assessing someone's mental state. What we're not going to cover tonight is suicide and risk. Now, don't get me wrong, this is absolutely a standalone lecture tonight. But I have done a previous one, which is available through the CPD Me portal. I think it's up on the YouTube as well. It very much works well with this. So if you weren't at my first seminar, I would encourage you to look at that. And as Andrew said, we're going to tie everything together with a third seminar on psychosis in the future. And I think they really do work well as a kind of, they stand alone, but they do work as a trio. So we're just going to start with some, facts and figures to set the scene. You've probably heard this statistic, but 1 in 4 of us will experience some kind of mental health problem. And 1 in 6 of us report having a common mental health problem, such as anxiety or depression, in any given week. In terms of specific diagnoses, some of the things that you might have encountered: mixed anxiety and depression, generalized anxiety disorder, PTSD, thinking about trauma, that's very in at the moment. There's a lot of research, there's a lot of new services around that. But if you look here, depression, 3 in 100 people. So these things are relatively common. And certainly, regardless of the field that you work in, you're going to be working with people who have mental health problems. Some of the other things that you may not encounter so much, or depending on where you work, but absolutely borderline personality disorder, otherwise known as emotionally unstable personality disorder. You've got bipolar, and you've got your more severe kind of psychotic disorders, including schizophrenia. These are a wee bit more rare than the common ones. Thinking back to our previous lecture, suicidal thoughts and self-harm aren't mental health diagnoses in themselves, but they are related to mental health. And these are fairly common experiences. If you look, 1 in 15 people attempt suicide, and 1 in 5 people have suicidal thoughts. So this is going to be happening to people that you know, patients that you treat, perhaps even loved ones or yourself. There's a lot of evidence to indicate that, yes, mental health problems are increasing. The trend does seem to be that the rates are going up, but this could be that perhaps the dialogue, the discourse around mental health is getting better, and thus people are more inclined to maybe seek support for that. There is a bit of debate on that. We've also got certain groups who are perhaps more likely to be affected by mental health problems. Now, I'm not going to read these stats out to you verbatim. We will be able to share the slides and the recording. You can have a look at that in a bit more detail. But some of the people who may be more likely to experience mental health problems are LGBTQ plus community, Black or Black British people, young women. There's certainly a trend for increasing mental health problems. And the other people that we know about are kind of those who are homeless, people with substance misuse issues, or people who come into contact with the criminal justice system, especially those in prison. It's important to note, I think, it's not the fact that you are gay or Black or Asian or homeless that gives you the, it's not the protected characteristic that causes mental health problems, but it's linked to things like social inequality, disadvantage, discrimination. If you think about maybe being bullied at school, you're not attaining, you're not forming social networks. It's this kind of injustice, this marginalization that helps create these mental illnesses. And this is why these populations are quite vulnerable to this. You might also have heard in kind of patient discourse or in medical notes, kind of SMI or serious mental illness. When we think about the NICE guidelines, this really is referring to what we call the more severe end of things like schizophrenia and bipolar. So this is the definition of an SMI. It's a mental illness that really has quite a lifelong impact and causes quite severe disability. So something like kind of mild to moderate depression wouldn't be classified as an SMI, but certainly you can get very, very severe forms of depression. So I think pragmatically, it's about looking at the degree of disability in the person that you're working with. One of the things as well that I'm really passionate about addressing is physical health inequality. I've put some papers in that you might want to look at in your own time. But what we know about people with severe and enduring mental illnesses is that they quite often have quite bad, comorbid physical health disorders. They die prematurely. People with schizophrenia can die up to 10 to 15 years younger than the general population. So there's a lot of work to be done here. And I think this is why you guys in the audience who are more on the physical health side of things, you play such an important role in addressing the physical health needs of our people with mental health problems. So I'm going to speak to you now about depression. We're going to consider this in a little bit more detail. And what I would like you to do, just for 30 seconds or so, obviously we're doing a kind of a seminar here, so I can't really do a group work exercise, but just take a few seconds to think about maybe patients that you've encountered that have had that label, who've self-identified or self-reported. Just think about how they came across, what they were like, what clinical features were present. I'm sure you've all encountered someone, and maybe just hold them in your head as we work through kind of some of the diagnostic criteria, and you'll be able to see how we pin a diagnosis on that depending on severity. So I found this a really wonderful visual representation of depression. I think it was in the Lancet or the British Medical Journal. It was a real big journal, quite a good piece. And what it proposes is that we break depression down into these different types of symptoms. So we've got our emotional symptoms or our psychological symptoms. We've got our neurovegetative in blue, and we've got our neurocognitive in red. Now, the depressed mood and the anhedonia, these are what we call the key kind of features of depression. Seems obvious, but if you don't have that depressed mood, we don't really pursue a depression diagnosis. But it's that anhedonia feature that's really, really important here. Now, what that means, like a lot of medical terms, it's derived from a Greek word, but it's the inability to experience pleasure. You probably all heard of hedonism, hedonistic lifestyles. So for people with depression, what they experience is literally the joy being sucked out of them. Think about the things that bring you joy, your family, your hobbies, work, anything like that that gives you joy, pleasure, that's gone. That's just all wiped out. Now, if you stack on top of that, it's quite common, these psychological symptoms. People quite often report feeling worthless, guilty, hopeless, like they're a waste of space. And if you live with that for a long time without help or support, that might eventually crystallize into some kind of suicidal ideation, plan, or attempt. Now, if we look at the other symptoms, this is where it's really important when it comes to our differential diagnosis. So fatigue or loss of energy, or sleeping lots, or sleeping a lot less, insomnia, or hypersomnia. Again, this can be a symptom of depression, but it can also be a symptom of a lot of other things. Likewise, weight gain, weight loss, or appetite going up or down. That can be a symptom of quite a lot of things. But if you pair this with the features that we've discussed above, the depressed mood, the anhedonia, this is where you start to build a picture of perhaps a more severe depression. And then at the end of the spectrum here, we've got that inability to think, concentrate, or being indecisive. Or in really quite depressed people, we might see what we call psychomotor agitation or retardation. So that's a real slowing down of the movements, or perhaps sped up, which is more common in things like bipolar. So the reason I draw attention to this is because it really can guide your clinical decision making when it comes to working out the differential diagnosis. So some of the things that we commonly would like to screen for, hypothyroidism. If people have got low thyroid function, they can present as quite lethargic, quite tired, quite irritable. They might report feeling low, they might report feeling depressed. And what we don't want to do is, if this is a new presentation, if we don't screen their physical health, we don't want to stick them right on antidepressants without getting to the bottom of any physical cause, because you've got someone then who's on antidepressants, all the side effects that come with that, but we've also got an untreated thyroid problem as well. Likewise, there's a lot of other things here that could be differentials for depression. Infection, think about the lethargy, fevers that come with that, feeling run down sometimes for weeks after the flu. Vitamin D, that's a really common kind of reason that people might present as a little bit depressed. So if you're in a position to take bloods, it might be an idea to get a vitamin D baseline. And B12, that's certainly indicated in mental functioning, certainly with depression, but definitely with dementia. If you're working with someone who's suddenly got memory problems and it's quite sudden onset, you definitely want to be checking their B12 levels before you progress down the kind of memory screen route, because that could be a really quick fix. And I've mentioned that below: dementia and delirium, multiple sclerosis, and of course, bipolar is a differential for depression. This is quite a handy chart, depending on where you are working. It is obviously of particular relevance to older people, but we quite often refer to the 3 Ds: dementia, delirium, and depression. And I think this chart is just a really nice way of helping to kind of work out some of the features that separate it. So if you look down the side, and I'm not going to read these all out, but some of the features that you might want to kind of interrogate in a bit more detail would be around the onset, the duration, what kind of activity is that patient presenting with? Are they alert? Are they able to pay attention to what you're saying? How's their mood? How are they reporting it? What about their perception of the world? And you can see here, you can start to tease apart some of these key differences. So for something like depression, before we make a diagnosis, we want to see that that patient has had that experience for at least 2 weeks, usually a bit longer by the time that they've presented. But whereas with delirium, if you work in an acute hospital setting, that can happen like that. That your patient becomes unwell very, very quickly. That's usually because of a reversible problem. Think about infection, constipation, med changes, intoxication, withdrawal, all those classic kind of screening tools for delirium. That's your root cause of that. But it does help you to visualize some of the differences in presentation. And it gets quite complicated. If you've got someone who does have dementia, whack a delirium on top of that, they might also have depression. So it gets very, very difficult to unpick it all. But I did find in clinical practice, especially in a liaison psychiatry setting, that was very, very useful in helping to suss things out a little bit. So we're just going to go on now to go through the key aspects of the mental state exam. And I think, we've got some mental health nurses in the audience. For you guys, you'll be very, very comfortable with this. This is our bread and butter. For those of you that perhaps aren't trained in mental health techniques, I think you'll find this is a really useful tool because it works almost like a semi-structured interview, but it's also based a lot on what you're observing. So you don't necessarily have to be an expert to start applying some of the principles. And I think as well, it takes away some of the mystery of what we do in mental health. There's a bit of a misconception that I sometimes roll my eyes at, that all we do is sit around having coffee and chatting to our patients. But actually what we're doing with the mental state examination, in my opinion, the findings from a good MSE are as valuable as that of a stethoscope, a CT scanner, or lab results. There's perhaps more of an art to its application and interpretation, but this is absolutely a valid clinical tool. So as we go through these next features, think about the main headings. Think if, are you familiar with it? Do you already assess people along these lines? Did you realize that you did it? And maybe think about, some of the general features that you might see in someone who doesn't present as mentally ill, but then start to think about some of the features in someone who is depressed, for example. So A and B, nice and easy. We've got appearance and behavior. So along these lines, you're thinking about this as soon as you see the patient. The minute that they come into the clinic room, the hospital ward, or if you present in an ambulance, if you're going into their home, you're making some kind of judgment on their hygiene. Is there evidence of self-neglect? What's the rapport like? Are they happy to see you? Most of our patients are. most people access healthcare because they've got a problem and they want some help with it. But for a lot of people, perhaps with mental health problems, they're not so keen on that contact. So maybe they are reluctant to engage. Maybe they're paranoid. Maybe they're suspicious. Maybe they're not able to warm up to you, as quickly. You're also thinking about eye contact, engagement, a bit of humor. We all use that. It goes down quite well. I think it's quite humanizing. It helps us to break down that us v them barrier. So if your patient is engaging in that appropriately with good eye contact, that's always a good sign. Intoxication, is it an acute issue, or is it a problem because they have chronic substance misuse issues and they're not able to care for themselves? Weight, really useful as well, especially if it's someone that you've known for quite some time. Getting that baseline is really, really useful. Now, weight is quite important to mental health in a lot of ways. People with depression, they might overeat or undereat. So, self-neglect, that can result in weight loss as well if people aren't eating properly. But you'll know that from other physical health problems, weight loss can be a real red flag. So you want to be considering this in terms of any kind of oncology cancer presentation. Likewise, weight, we don't really cover it in this session. This is such a complex issue, but eating disorders, that's really, really important, particularly for people that are starving themselves, that we typically see in anorexia nervosa, or restricting calories, compared to perhaps, say, the purging behaviors that we see in bulimia nervosa. So all in all, again, you don't have to be an expert, but every one of us, we've got that healthcare provider instinct. We can make a bit of a judgment on someone's rapport, how they're getting on with us, what's happening with them. And going back to some of those more complex terms that I mentioned before, you might want to assess their psychomotor activity, any involuntary movements, or any slowing down of their actions. Speech, again, fairly straightforward. But what we might be looking for here is the rate. Are they talking very, very fast? Maybe we would see that in someone with bipolar, whose thoughts are racing, who's quite manic, who's quite elated. We can refer to that as their pressure of speech. Are they going a million miles an hour to try and get everything out? Are they going a bit too quickly? You can usually tell that within the first few seconds. You've got an idea here called poverty of speech. Are they saying anything? Is that content meaningful? Is it spontaneous? I'm sure we've all had these encounters where it really is difficult to pull the words out of someone. You're getting that one-word response, monosyllabic. You're giving it your all, but you're just not getting anything back. This is quite important when assessing mental state, because it could be a sign that someone's quite severely depressed, or it might be that they're guarded, suspicious, paranoid. Think as well about the content. You're probably going to do an assessment of thought at the same time that you're assessing speech, because that is a reflection of someone's thought content, thought processes. M is for mood. This is quite a big one, obviously, especially if you are screening for a mood disorder. But what we're thinking about here, and I think a good analogy, mood tends to be what the patient describes. And if you ask someone their mood, they'll typically report how they've been feeling, consistently over the past few days or weeks. So they might say that they feel flat, they feel okay, they feel good, they've been a wee bit low. This is quite distinct from the effect. So the effect of someone is what you see. It's what is immediately obvious. Is someone happy? Are they upset? Are they sad? Are they crying? Are they angry? So a good analogy is mood is like the climate. It's more consistent. It's more kind of a picture over time. And effect is like the weather. Up in the northwest of England here, it's very rainy outside, which I'm sure a lot of you can agree with. So that's the analogy that we use. But other factors that we look at when we think about mood, are they irritable, euthymic? That's just a fancy word for a kind of an okay, normal mood. Are they labile? Are the moods up and down very, very quickly, very rapid? Are they going from laughing to crying? We might see that in disorders like bipolar or certain kinds of personality disorder. I think congruency, your gut feeling is really, really important here. Do you get a bad feeling in your gut that someone is telling you something about their mental state? They're saying that they're okay, they feel absolutely fine, but actually, you feel that things aren't going so well. This is quite common in people that maybe are thinking about suicide, maybe who've attempted suicide and it's been unsuccessful. They can quite often report, especially in emergency psychiatry settings, that, oh no, it's fine, I regret it, I wish I hadn't done it, but something just feels off. So that's where that congruency is really, really important. Does what they say match your kind of clinical findings, your observation? This tends to be a good point to ask about suicide, if you haven't already. Again, there's debate on when you bring it up, if you should for every patient. I think for you guys who aren't mental health specialists, you're not going to be talking about that in every encounter. But if you do refer back to my previous seminar, it might help you to perhaps understand where these conversations could be applied. T, I mentioned before, we're thinking about thoughts. Now, when we assess thoughts, we think about two aspects. We think about the form. So what I mean by that is the flow, the pace, the order. Is it logical? Are they distracted? Is it tangential? Are they flitting from subject to subject? So that's kind of the form of the thought, the structure. But more importantly, we've got the content. And you've probably got an indication of this when you are thinking about speech. So when you're assessing someone's speech, you're assessing what they're saying. Are there any delusions? Are there any obsessions? Are there any suicidal thoughts, violent thoughts about themselves, others, perhaps you? Do you need to keep yourself safe in this immediate situation? When we talk about psychosis in a future seminar, we'll be thinking about this idea of things being grounded in reality. We'll be thinking about the definitions of psychosis. But certainly when we are looking at someone's thoughts, we might want to be thinking about thought insertion, thought withdrawal, thought broadcast. And these are all disorders that we see commonly in schizophrenia, whereby people think that thoughts have been taken out of their head, or that their thoughts can be read by others, broadcast. Think of an old-fashioned radio. And that can be very distressing for people. P, also linked to psychosis, but perceptions are more importantly, abnormal perceptions. Now, hallucination is in a nutshell, it's the experience of a stimulus that doesn't exist. So people who are psychotic, if they hear a voice, they will hear that the same way that you can hear mine now. It's very distinct from it being in your head. We refer to it as a kind of third party. It's an external sensation. So again, if you're experiencing this for the first time, it's quite common to be quite frightened, quite distressed. The main types of hallucination are auditory and visual, but you can have hallucinations of any of the senses. So you can have olfactory, tactile, which is touch. I once nursed a woman who had an absolutely awful ordeal where she was having tactile hallucinations that she was being raped. And it was so distressing for her and the people caring for her, because until that lady was kind of calmed with medication, that thought was very, very real to her. So again, I think I'll explore more of these kind of case studies in a future psychosis seminar. C, cognition. Any of you that work with older people will be quite used to assessing cognition, but it's not just for older people. So someone's orientation to time, place, person, that's really, really important. That can help you suss out, is there an acute issue? Are they delirious? Are they perhaps confused? Are they lost? But you don't necessarily have to be delirious to have issues with your concentration, your memory, or being able to pay attention. People who are very, very depressed find it difficult to pay attention for long periods of time. So they might not even be able to, engage in a full consultation with you. Some of you might well be familiar with the mini mental state examination. That's when you screen for dementia. But absolutely, when we think about cognition, we're also maybe having to assess someone's capacity depending on what that clinical decision is. Now, I is for insight. This one's a wee bit more trickier. I think it's very important in mental health because I think insight in mental health services, it's quite common that there's maybe a mismatch between what we perceive and what we feel is an objective picture as the clinician and what that patient or what that person is actually experiencing, especially in psychotic disorders. We've established that that's about a loss of touch with reality. So quite often there can be that kind of mismatch in insight. By and large, people that are kind of mildly to moderately depressed will recognize, acknowledge that they are depressed. So there doesn't tend to be any huge issues with insight at that point. But it is a good opportunity for you to maybe establish your client's understanding of what their current problems are. And I think, what I just wanted to get you to do, maybe now or as you go forward with this, is just reflect on your role. Some of you will have more direct input with mental health patients than others. Primary care providers, if you're working in GP, maybe as an advanced practitioner or nurse practitioner, you might see anyone that walks through the door, in which case you are actually going to have to do a lot more work with people with mental health problems. You might be the one screening, you might be the one, making an onward referral. I guess people that don't tend to have so much direct input for mental health would be physiotherapists, but any healthcare professional can be someone who a first disclosure is made to. So you might be a physio with absolutely no background in mental health, but actually you've got a patient who comes along, they haven't spoken to anyone in weeks, and they tell you that they feel suicidal or they feel depressed. So you may well have to be the one that kind of takes action on that. So what I thought, just to pull this all together before we think about some other elements, I've just included a few basic phrases that might help you gather information. And, these really aren't rocket science at all. But if people are maybe a wee bit worried of how to approach these conversations, I just wanted to reassure you that there's no such thing as saying the wrong thing. People maybe feel a bit fretful that they can't bring things up, such as mood, suicide, etc. But as long as you're asking that question in a sensitive way, a patient's never going to take offense. You're never going to put the idea in the head. So it was just to give you that reassurance, really. Some of the things that you might ask about mood: how are you feeling today? How's your mood been over the past 2 weeks? Have you been feeling low, depressed, or anxious? Are you worried about anything? Just a point on that, if you've got someone that isn't being very spontaneous, if they aren't very talkative, you might want to focus more on closed questions. But it's also a good idea to throw in some open ones if you can, because that way you're getting more of a narrative, subjective experience. Mentioned that this is going to be of more relevance to those people perhaps in primary care or paramedics having to make a decision. If you don't feel confident in your MSE assessment skills just yet, there's various performers and tools that you can use to supplement your decision making. So you might well be familiar with the PHQ-9, Patient Health Questionnaire number 9. Don't ask me what 1 through 8 are. But these in effect help you to screen, diagnose, monitor, and measure depression. It gives you quite a nice number. The cutoffs are very clear. I can't remember off the top of my head, but say it's less than 8, no depression; over 8, moderate; over 12, significant. So that can help you to triage and make appropriate referrals. It can also be good if you are a therapist. If you're starting someone on a course of CBT, it's quite common that you administer a PHQ-9 pre-therapy shortly afterwards and then at the end, because it gives you a very objective kind of, has this worked? Has the depression improved or got worse? Some other useful scales are the GAD-7, which is your generalized anxiety disorder 7-item scale. One we used quite a lot in liaison psychiatry was the HADS, the Hospital Anxiety and Depression Scale. So if we've got anyone on the call who does work in a hospital, I do think that you should maybe use these tools. The reason that they're so specific to hospital is it kind of cuts through the heart of the matter And it helps you to tease out what is genuine clinical depression versus what is someone who's just fed up because they're in hospital for 3 weeks. They have to be £10 a day to watch the telly, the food's rubbish, that kind of thing. You know, that would get most of us down, but it's not going to make all of us clinically depressed. So that can really help to tease out the difference there. It's a really, really good tool, and it's really useful when you're making onward referrals to liaison psychiatry. Just getting back to some kind of questions, and again, we will go into this in more detail in the psychosis seminar, but if you want to get to the heart of, you know, maybe what people are thinking, feeling, you could ask what's on your mind. Do you ever feel that people are out to do you harm? Do you ever see or hear things that other people can't see? So this is when you're trying to establish if someone's psychotic, if they're having hallucinations, if there's that disconnect with reality. And again, as I mentioned before, there is a full other seminar on this, so I'm not going to talk about this at length, but these are some questions that you might want to introduce if you are worried about someone's risk of harm to themselves. And depending on that response, you might want to follow up to work out how immediate that threat is. You know, a lot of people who have suicidal ideation have absolutely no plans to act on that. Suicidal ideation itself, relatively common, and not something that we're overly worried about, but it's when people progress to that kind of real intent with an active plan that we want to get worried. So just a few notes on treatment options. You know, so for depression itself, the vast majority of that takes place at primary care level. Now, you may well have seen on Twitter or kind of through clinical updates that NICE guidelines now very clearly state that for mild depression, medication is not indicated. Exercise and lifestyle advice is more effective than medication. You know, I am a prescriber. I think there's maybe a little bit of a problem with overprescribing of antidepressants. I think because they are kind of dispensed at GP level, there's maybe a misconception that they aren't serious drugs, or, you know, everyone can have them. But when you look at the side effects, the withdrawal effects, you know, some people, their sex lives get absolutely destroyed by antidepressants. For me as a prescriber, it's a big, big decision to start someone. And I think this guidelines, I really welcome that, because it's trying to reduce that overprescribing. You know, for mild, then therapy is certainly useful. You've probably heard of CBT, cognitive behavioral therapy. IAPT is a big scheme that you should probably get familiar with. It stands for Improving Access to Psychological Therapies. It's been a while for a little while now, I think from the new Labour days. But that's to kind of help alleviate some of the burden on primary care. So most places will have an IAPT provision, which deals with therapy at that kind of primary care level. The gold standard for moderate to severe depression is medication plus therapy. You might well have heard of SSRIs, such as sertraline. Certainly at the more severe end of depression, that's when you want to involve secondary care. And some of the features that you might want to look out for are, is it treatment resistant? You know, have you had a go at rectifying this yourself, but they're just not getting any better? Are there significant risks? Is it a psychotic depression? I would encourage you all to look up these guidelines, because what it does is it helps you to triage it into, you know, part one is around more mild, and it gives you some tips for that. So, you know, for a few your symptoms with little associated disability, maybe there is a bit of a stressor going on, nothing major, there's no significant history, there's plenty of support available for the person through family, and there's no suicidal thoughts. Right up to category 4, which is the far more serious end of the spectrum. You've got someone that's actively suicidal. They might have a specific plan. They might have psychotic symptoms. They might have severe agitation or self-neglect. This is absolutely the kind of presentation that would warrant a referral to secondary services, urgent care, maybe even A&E if the risks were imminent. And again, I've not put it all in, but if you go back to that kind of link, you'll see what the threshold and criteria is at points 2 and 3 as well. Just wanted to touch on bipolar. I mean, I can't do it justice within this wider lecture. You know, it would really need one of its own or to fit in. Maybe I'll touch on it in the psychosis lecture, but it's just to give you an idea of the spectrum that we work with. So you've got the kind of normal here. Normal is fine. If people kind of stay normal, then they're not going to have any clinically indicated low mood or manic mood. You may or may not be aware that bipolar can be categorized into 2 types. You've got type 1 and type 2. Type 1 tends to be the more severe end, and you'll see here that the threshold or the boundary goes way up to mania, whereas bipolar type 2 tends to the threshold for that is severe depression to hypomania. Now, you might not be familiar with that term. I think there's a little bit of a misconception when we think of manic depression, which is what bipolar used to be called. Hypomania is just a state below mania, and a lot of people experience that, and it's actually quite pleasurable. People feel confident, they feel on top of the world, they're making good decisions. Maybe that confidence is meaning they're getting on well at work. Maybe they are out on the pool and having great success with it. You know, people in that hypomanic state feel wonderful. And there's a reason that bipolar could be misdiagnosed as depression for many, many years. Because if you think about it, if you're feeling wonderful, having great sex, you know, getting promotions at work, you're not going to go to your GP, are you? You know, what often happens with bipolar is that it's people's family or employer, or maybe they get in trouble with the police when they've tipped into that manic phase. And that's when we've got that significant loss of function. That's when we've got dangerous activity, drugs, alcohol, drunk driving, maybe high-risk sexual behaviors, and tipping over into delusions and hallucinations. The thing about bipolar is that people, when they experience that low phase, it tends to be quite severe. So you can see here down at the severe end, you've got that anhedonia, apathy, insomnia, suicidal thoughts. And in between that, you've got cyclothymia, which is a kind of persistent mood disorder, but doesn't get hugely to either side of the spectrum. You've got dysthymia, which is kind of ongoing moderate depression, kind of crappy mood, but not with the associated severity or risks, and certainly not with the mania. And of course, we've got our good old unipolar depression, which just means depression that doesn't have a manic side of it. So yeah, I said that already about psychosis. We can touch on that later. And I just wanted to kind of, as we come to the end of this, wrap up with how services are structured. This will vary depending on where you work, but I just thought, you know, it's going to apply to most regions. I know we've got an international audience here, so it is a very UK centric perspective. And even with that, there will be regional variation. But, you know, your GP, your prescribers are going to be responsible for antidepressants in most circumstances. You've also got your IAP services. Now, provision will vary. Across the country, it tends to be kind of mixed provision between NHS and third sector as things are contracted out. I've put in here for anyone that is based in Manchester, the main organisation that kind of does our IAP stuff is Self-Help. They do a lot of therapy online, self-help resources. So this can be a really good resource for you if you want to be able to signpost someone, but also for you as an individual, you know, if you are struggling with maybe work-related stress, for example. Secondary care, some of the terms that you might come across, single point of access. Most mental health trusts will operate some kind of single point of access, that if you've got a worry and you're not quite sure how to triage it, you can make a referral and they will filter that into the right service. We've got community mental health teams. They tend to work with people with an SMI, so people that have got quite complex needs, but who aren't maybe acutely unwell or who aren't acutely risky. We've also got home-based treatment teams, and the remit of them really is for hospital avoidance. And at the more extreme or sort of emergency end of the spectrum, we've got liaison psychiatry and emergency urgent care. So absolutely, if you're worried about anyone's immediate risk to themselves, just get them down to A&E, no questions asked. You can never do the wrong thing with that, even if you're not quite sure. So what I would say, it will help you out is if you can get familiar with local mental health services. Some of the terms might be interchangeable. So crisis team, home-based treatment team, crisis resolution, all kind of mean the same thing. Liaison, A&E liaison, liaison mental health, access duty, single point of access. What I think you should do as well is maybe Google or whatever your search provider is, local location plus IAP services, so Bristol IAP, Manchester IAP, Glasgow IAP, and that should come up with a list of who provides it around there. You might also want to go for, Manchester Mental Health Services, Norwich Mental Health Services, and you'll get a breakdown of how that is structured. So come quite abruptly there. It took me by surprise. I'm more than happy now to go on to any questions.
There you go. Stephen, thank you very much indeed. I was just going to type into the chat that actually, if you can shadow or arrange to go and meet some of these services, it will be an absolutely huge advantage, because certainly from my advanced practice perspective, I got the opportunity to go and shadow an emergency duty team and equally a MASH team, and it just leaps and bounds brought on my underpinning knowledge. And what it certainly helped with was thresholds, because my threshold as a frontline emergency practitioner is completely different to what theirs were as a responding team. So it just helped break down some of the barriers. So if you do get opportunity, or you can indeed go out and shadow some of these people, I know it's not as easy as we think it is, but if you can go out and shadow some of these people, then please do so, because it will be a brilliant opportunity for you to do. I can't help with that, but if you can arrange it yourself, then please do see if you can do so. I'm just going to allow people to put some. We've got 4 questions lined up for you. Some really good comments for you in the chat. But I'm just going to tell people some bits about what's coming on shortly. This recording will be available on YouTube for 24 hours. And then it gets pulled off YouTube and then gets put onto the CPDME portal. So if you are a member of CPDME or you've downloaded the app, you will be able to access it from tomorrow onwards, but it will be available on YouTube until it's about 24 hours time. So if you haven't subscribed on YouTube, please do so, because we equally put some amazing tips and tricks on there for capturing and recording your CPD. Certainly for people who struggle with things like, what can I include? What should I exclude? And we equally have around 5,000 people per month get audited in the system. So as they feedback some tips and tricks to us, we're going to start posting some tips and tricks on YouTube. So it'll be really good to subscribe on there and follow us, because you're going to get some real life testimonials on there for people who use the system and who've been audited, and some of the tricks around top tips, around making sure that you're fit for practice. Speaking of which, if you fancy a little time on camera, we're going to give some 10-year free memberships away, which is a high 170 quid according to my primitive maths. But that's about 170 quid. What we want you to do is give us some video testimonials. So I did see in the chat that there's people who's been audited and who use the CPDME system, or just simply how you use the system and how it makes it simple for you. If you scan that QR code and you leave us a quick video testimonial, I think you've got to answer 3 questions. We will make your membership free for the next 10 years, and we'll also send you a little goodie bag in the post as well. So please do scan that QR code, because your feedback for us is really important. Equally, in the chat, I have put some links in there for the feedback. Thank you, Haley. I've just seen your Google review. You are the one and only Google review up to now, so that's pretty much so if nobody else leaves us a review before the end of tonight, you've got yourself a voucher. But if you want us to cover any more subjects in these webinars, please do pop it into the chat. If you want us to cover any specific areas around mental health or psychosis and such, or even other subjects that we can teach to our health and social care community, pop it into the chat and I'll give that to Sarah, who's our new marketing person who's starting tomorrow. So make sure you tell us what you want, and we will make sure we try and tick as many boxes as we can for you. So some questions for you, Stephen. So do you ever use sad persons as a screening tool? I know this tends to be one of the tools that some doctors in our ED use.
So no, I don't. And the reason for that, sad persons, for people who are thinking that's an unusual question, it's an acronym. And I can't remember exactly what it stands for, but I think it's to do with maybe single, alcohol dependent. It's all kind of demographic risk factors associated with suicide risk. The reason I don't like it is because it's purely demographic. It's not an assessment of that patient's individual factors. It's purely a paper exercise of boxes that they fit into on paper. And I think if we use algorithms to make our decisions, they're not going to be safe. They're not going to be accurate. So no, I don't recommend it.
Okay, we've got a question in the chat from Craig. If a patient has capacity and has taken an overdose, so can refuse transport to ED. Where do we stand with Mental Health Act and forcing them to ED? Difficult in having the correct professionals. Good question, Craig.
Really good question, really complex question. I'm assuming that's maybe a paramedic perspective. I know that you guys are quite often in difficult positions where you are that first responder. Maybe you've gone to someone's home, maybe they've disclosed something like that. A hell of a lot easier to do these capacity assessments when someone's already in hospital in a safe place. What I would say is that, yes, by and large, if they have capacity, you are limited in what you can do. But this is where the Mental Health Act has kind of specific powers, in that if someone is detained, there are certain circumstances where someone can be detained and actually have capacity, and we can still treat them. Now, it gets really complicated because technically the treatment of an overdose is a physical health matter rather than a psychiatric one. The suicide attempt is perhaps secondary to a psychiatric disorder. But I think if you're ever in that position and you are stuck at home with someone, you're worried about the capacity, I would always be getting some advice from a mental health practitioner, because it might not be that clear cut. It may well be that their capacity is impaired because of psychosis, because of depression, because of something else, but you might not have the tools to recognize that. If in doubt, you can always get the police. I think they've got a kind of life and limb law that does support them getting people to hospital if it is for life-saving treatment.
Thanks, Stephen. And also, Craig, remember that if you have got an escalation plan or a grown-up at the end of a phone, then use them as part of your decision-making process, because capacity is transient and it can change. And you could argue that if they've taken a substantive overdose, that eventually they will have an impairment of the body and mind. So escalate, don't procrastinate, would be my best advice for you. And having sat in a clinical support hub for about 5 years of my career in the past, make sure you involve as many people as you can, because a decision shared is a decision that you don't need to take home with you and worry about given you making the decision alone.
Absolutely.
Next question. We've got a lot of anonymous questions tonight. Is there ever a situation where you would not recommend talking therapies, i.e. just go for medication alone?
I think we would always perhaps offer, that is the gold standard. What I would say is that a lot of people just aren't psychologically minded. A lot of people just aren't built for therapy. They perhaps don't want to engage. They don't understand it. They see it as a bit silly. Maybe they don't want to open up because they feel it's touchy-feely. There's a lot of people for whom therapy is not going to be a good option, and that's absolutely fine. It's not going to be for everyone. But I wouldn't make any hard and fast rules that therapy would ever be dangerous for someone. But maybe for someone that's particularly traumatized, they are not quite ready to engage that process. An example I'll give, the guidelines are very clear that for kind of grief therapy, you don't do that until at least 6 months after the death of a loved one, because in that 6-month period, everything you're going through is perfectly natural and normal as part of the grieving process. So that's one example, I suppose.
Excellent. Thanks, Stephen. Hillary's put, very interesting, will be very helpful in a new job as a mental health practitioner. Thank you, Hillary. I wish you all the best in your new job. I've no doubt there are some lots of challenges ahead for you, but good luck. Alan, currently the waiting time for an appointment in my area to IAPT is currently 10 months. What would you suggest are the alternatives?
So, yeah, I mean, I think it's a really good point to raise. NHS services are slammed at the moment, and sometimes we do have to tell patients, look, I'm really sorry, I know you need this therapy sooner rather than later, but it kind of is what it is. What I would say, though, is if you do that search like I suggested, so the self-help services, for example, a lot of the things that they offer are self-directed. There's online therapy. So while it's not fully the same as getting that one-to-one in the therapist office, there are things that can hold people over. Of course, risk can change. I think to safety net people, I think you should always tell them that, you know, A&E is there. Increasingly, you've got alternatives to A&E. You've got mental health trust crisis lines or places of safety that are away from that chaotic, busy A&E department. But I think you really have to look up your local services. And it might well be maybe you want to ring the single point of access team and ask them what they suggest on that one.
Yep, I've just put a link in there. There's a website that I used to use called Hub of Hope, I think it's called. I don't know how updated it's kept now, but it used to highlight all associated services around, a bit more useful than Service Finder. I've just popped it into the chat there, so just Google search Hub of Hope. There's some useful links on there. Anonymous, in brief, what is the admission criteria for depression?
So I think I'm assuming here that mean kind of admission to psychiatric inpatient unit. I think the depression would have to be quite severe. If we think back to that spectrum that I gave, the graphic, I think the more severe the depression, the more of those symptoms that you will have. Of course, increasingly, you know, psychiatric admissions are really based around risk. So if you've got someone that is severely depressed, maybe the self-neglect is severe, they're not actually looking after themselves, or if there is a kind of a serious suicidal plan in place, that would really be when you're thinking about hospital admission.
Excellent. I think you've probably just answered Donna's question there. And so, Stephen, that is it for this evening. Thank you so much indeed for your time yet again.
Pleasure.
So we're going to have a chat offline and we're going to talk about psychosis, and then we're going to talk about maybe some little bite-sized nuggets of primary care, low acuity mental health tips and tricks that we can broadcast to our fabulous community who have been excellent tonight and an amazing audience.
Yes, thank you very much, guys. Wonderful.
Thank you. The chat is lighting up with lots and lots of thanks there for you. So on behalf of myself and all the amazing team here at CPDME, who really aren't here because they're probably at home sat having a glass of wine, watching me and Stephen jibber jabbering. But on behalf of myself and all the team, thank you so much for your continuing support. It really does mean a million points to us all. If you haven't already, please download the app and have a look at our up and coming webinars. And we have got lots of exciting things coming for you in the next few months. So stand by. If you're at home, kick off your slippers, enjoy the rest of the evening. If you're at work, please stay safe, and thank you for supporting CPDME. Take care, everybody, and good night. Thank you.
Bye-bye.